The patient and healthcare system should embrace two major objectives in managing painful injuries or medical conditions when they occur. First, managing the injury and associated acute pain effectively to prevent pain from becoming persistent. And second, with acknowledgement that some conditions inevitably cause persistent pain, preventing the biopsychosocial cascade of persistent pain progressing to complex chronic pain, with its associated physical and psychosocial consequences and its functional losses, including work disability, emotional distress, family stress, cognitive impairment, depression, substance misuse, and even suicide or unintentional overdose. This transformative process is called the chronification of pain cycle, which involves the complex interaction of the patient's own physical and social environment with the patient's neurophysiologic pain processing systems, including the transmission of peripheral stimuli, or whatever disease or injury is activating the pain signal in the body, and the processing of that painful stimulus in the central nervous system, which consists of the spinal cord and brain. If the painful stimulus continues, be it from irritation of the injury or from ongoing local inflammation, peripheral sensitization occurs. Pain receptors in the injured or inflamed tissue and the nerves connecting them to the spinal cord become more sensitive, causing the area to be even more painful when stimulated, which is called hyperalgesia. If pain persists, particularly when paired with stress, worry, and anxiety, then central sensitization increases the brain's attention to the pain signal and the likelihood that secondary neurobehavioral conditions will develop, such as sleep, anxiety, and mood disorders. These complicate the clinical picture and change behavior, potentially straining relationships and patients' roles in their communities and families, for example, work, parenting, marriage, and friendships. So whenever a provider sees a patient with chronic pain, the first action should be to identify where that patient is in the chronic pain cycle. To explain the cycle, let's start with acute injury and pain, which activates neurogenic inflammation. If pain persists, it can progress to peripheral sensitization, which involves changes in peripheral nerves and a lowering of the threshold for activation of pain in the body. Further persistence can lead to changes in the central nervous system, called central sensitization, with neuroplastic changes in the brain, which activate even more sensitive pain responses to the injury or disease. Pathophysiological factors in the body can perpetuate the painful peripheral stimulus and the central activation of pain. Some examples include radiculopathy from a herniated or leaky intervertebral disc in the spine, traction on nerves from scar tissue or neuromas following surgery or severe trauma, or activation of pain fibers and muscles or their insertions from injury or disease, which then become sensitized and cause trigger points or sensitive areas in the muscles that cause pain. Each of these, if not diagnosed and managed effectively, can cause a continuation of pain for many months and years. As for the brain, there may be a reduction of cognitive function in response to persistent painful stimulation that interrupts the mental processes necessary for functioning at the highest level. So patients with chronic pain may say they're getting by, but are not functioning at their best. The provider's job, of course, is to reverse some of these neuroplastic changes so the patient can function at their best. Then there is the suffering of chronic pain to consider, which is the emotional aspect of pain. Not where the pain is felt in the body, but the degree of suffering or distress caused by the pain. Understanding the distress of pain focuses neurophysiologically on the interaction of the anterior cingulate and other brain regions that are involved in the suffering of pain, anxiety, and mood disorders, and neurobehaviorally on how a person's interpretation of the pain affects their emotional and behavioral ability to cope effectively. When a painful injury occurs in a stressful environment, the stress and pain are encoded together through hippocampal memory mechanisms in the central nervous system and can activate each other in the future. An anxious or depressed mood lowers the threshold for experiencing the unpleasantness or suffering of a painful stimulus, what we term as emotional allodynia. Similarly, pain may activate anxiety and PTSD. This is why persistent pain, PTSD, and other emotional disorders must be treated together when they co-occur. As more pain is experienced, causing losses such as physical and social functioning, resulting demoralization increases the risk of developing major depression, even when a person has no past or family history of depression. We now know that chronic pain is an independent risk factor for suicide. So these issues, the emotional, physical, functional, interpersonal, and spiritual consequences of pain, must be evaluated and addressed in every patient with pain. Once the pathophysiology of maintenance in the periphery or in the brain and the emotional maintenance factors are developed, disability may occur. When someone has chronic pain, they are less active and can become afraid of moving and activating the pain. This is called kinesiophobia. When there is diminished motivation to do things, a patient can become depressed and isolate themselves from their workplace because they can't perform their job, or from their hobbies or friends because they can't participate in normal activities. They lose their role in life. In addition, muscles can atrophy from the lack of movement. They can become weak, tight, and more prone to re-injury, as well as bone loss from inactivity. Another common side effect from chronic pain is developing a sleep disorder, which worsens pain and the ability to cope with pain. When seeing patients with chronic pain, or even patients with acute pain from injury or post-surgery, be sure to consider the chronification cycle, from acute pain to chronic pain, and develop a patient-specific intervention plan that addresses where the patient is in this cycle, as they could be in several different places. Use a biopsychosocial pain management approach that includes considerations for the patient's social and psychological states, as well as their biological functionality. Think of how to interrupt these processes. Then, work to reverse each one as much as possible with mechanism-based treatments that address each one of the areas separately but collectively.